generous in your using your words, and thank you so much. And equally proud of having you as my colleague for almost about 8-10 years, and it's been a mutual learning. Don't think it was a one-way phenomenon. Very silently, I also learned a lot of things from you as well. You are a wonderful human being, a great clinician, and a very keen learner. And I think the others might get sort of annoyed with us that this might become a sort of a mutual appreciation group. And before that happens, let me get across to my presentation. What I will do is I'm just sharing my screen, and can you guys see me, and can you guys hear me?
Yes, go ahead, Ashok.
So what I thought that in the next 10 minutes, I would sound a little different, not for the sake of it, but for the completion of it. And I would take you through the entire spectrum of immunotherapies, though we would be discussing elegantly, extensively over the next 2 days about the immune checkpoint inhibitors, and because that is the real the topic for the current era. But I would take you through some of the less talked about concepts in immunotherapies as well, and very quickly show you some of the other concepts as well. As such, it is rightly said that immunotherapies have emerged as one of the strong pillars of oncology, apart from radiation, surgery, chemotherapy, targeted drugs. And who knows, this jigsaw puzzle would start getting extended to the left and the right, up and down. And then the more it happens, the better it is for the clinicians, and more so for the patients and their families. Patients are surviving longer with less toxicity and more convenience. Look at the spectrum. There are, other than immune checkpoint inhibitors, there are many cell-based therapies we clinicians talk less about. And I would show you that some of these are very robust, less talked about, less applied, because these are, pardon me for saying that, these are not off the shelf. These are customized. Every individual has to have his own customized therapy, because these are cell-based, and immune checkpoint inhibitors are off the shelf. These are more pharma-driven, and therefore can be subjected to mass production. You have a companion diagnostic, and then you have a drug, and the combo goes on. But don't forget the other therapies which revolve around the tumor-infiltrating lymphocytes, teaching these lymphocytes newer tricks, and causing these lymphocytes to work in a different manner to attack the tumor and cause the tumoral lysis in these patients. The basic is the activation of the killer T cell is the basis, at the heart of it. And once this switches on, this can go and attack the tumor in different variety of ways, and then this can happen through the tumor-infiltrating lymphocytes, NK cells, and others, and so on and so forth. Immunotherapy, we know, is not a new subject, and we have had over the last 30 years many attempts at manipulating these cells, bringing them out, expanding them, and then putting them back into the body, transinfecting them with the viruses, producing those CAR T cells, and the story is on and on. And the latest out here is the many immunotherapy, the immune checkpoint inhibitor drugs getting approved for these indications. The TILs, because tumors have these infiltrating lymphocytes, there is an opportunity to activate them and expand them ex vivo, reinfuse them, and use them to destroy the tumors. Again, the entire story revolves around the switching it on and getting the tumors to be attacked by these tumors and by these cells. One could expand them ex vivo, reinfuse them, and the whole technology could be harnessed by expansion, by increasing the numbers. However, it's not only limited to increasing the numbers. These could be activated by equipping them with new T-cell receptors, and both the numbers as well as the new receptors done ex vivo, these could be infused back and could be harnessed for tumoral lysis. The big story of the last decade is the CAR T cell therapies, and both the tumor infiltrating lymphocytes and TCRs can be used to target the cancer cells when the antigens are bound by the MHC. Remember, these need MHC expression of these antigens. However, the CAR T cells can work even without the MHC, and these can only recognize a small spectrum of the antigens which are naturally expressed on these cells, like the CD19. And there is a range of potential antigens which can be harnessed for producing the CAR T cells. The process seems simplistic, that we harvest the peripheral PBMCs, the mononuclear cells. The patient receives the lymphocyte depleting chemotherapy, and these cells are taken out in the lab. They are transduction, and the retroviral transfection is done. The CAR T cells are produced and fused back. The process has undergone a lot of modification. Earlier, all this used to be done on different benches in the lab. Now there are integrated systems where you all put it as a cocktail, and after 5 to 7 days, you get the finished product of these CAR T cells. There are generations to that, as happens with most of the biological products, and it's the intracellular domain which are the co-stimulatory molecules which make the CAR T work better or more specific. The good old story of the first CAR T success from the University of Pennsylvania. This was a CLL, but the story is moved on, and then we know that the profound effect in lymphoblastic lymphomas who had undergone extensive treatment, even allogeneic transplants who had failed, they have had durable responses with CAR T cells. So that is the great success of the last decade. Two of these medications or these biological products which are available commercially, Yescarta and the Chimera with their complicated names, these are commercially available and approved for the B-cell malignancies. Natural killer cells are the latecomers. They are also being explored in conjunction with others. And the next two slides show you the number of opportunities, number of antigens or the surface molecules which are the subject of target for these CAR T cells. And imagine these science is ever expanding. Last but not the least is the dendritic cell. This is a slide from Steinman's Nobel Prize presentation. Again, the PBMCs are harvested. They are cultured with growth factors. Part of the tumor repertoire is introduced into this. These become immature dendritic cells, and they mature over a period of time ex vivo, and millions of these dendritic cells are reinfused into the body, who have been taught how the tumor antigens they look like, and then these are the ones which are harvested and done. This was our publication, and this was a group of patients who had been very, very extensively treated, and there were some meaningful responses, and based on this, the Government of India gave the approval. And this is one of the microphotographs from one of our CAR T, the dendritic cell preparation. Millions of these cells are put back into the body, published in Cytotherapy 2014. Big story, immune checkpoint inhibitors. Sachin just made a mention about the number of these therapies which are available, and I just did a count on that. The 5,000 plus therapies based purely on biomarkers. And that is the number of trials which is on. This is the slide you would be seeing over the next 2 days many, many times. And the immune checkpoint inhibitors being approved in every and any condition, talk about that in different settings, different lines of treatment. I can't take you through all this. I come to the end of my presentation with a slide showing what is FDA approved. The three of these therapies are FDA approved: CAR T cells, dendritic cell, as well as the immune checkpoint inhibitors. A lot of work still needs to be done on the TILs and the NK cells and the engineered TILs, which are the T cell receptor manipulated cells. I thank you for your patient listening, and back to Sachin, over to you. And I thank you for this opportunity